All right, welcome to Quickshot session number 3, Trauma and Neonatal. My name is Marisa Schwab. I'm a pediatric surgery fellow at Stanford.
And my name is Pavin Burmamdam. I'm a pediatric surgeon from Corewell Children's outside of Detroit.
All right, our first presentation is by Dr. Haley Etzkovitz, and it is entitled Long-Term Clinical Outcomes for Patients with Small Intestinal Hirschsprung Disease.
Hello, everyone. Thank you for the opportunity to present our work. I have no disclosures. Small intestinal Hirschsprung disease is associated with significant morbidity, often due to long-term parenteral nutrition requirements and the development of intestinal failure-associated liver disease. There is little known about the long-term outcomes of these complications and factors related to prognostication in this patient population. To better elucidate prognostic factors, we performed a retrospective cohort study of patients managed by our multidisciplinary intestinal rehabilitation program over a 10-year period. Of the 588 patients in the program, 46 had a diagnosis of small intestinal Hirschsprung disease, which is 7.8% of the patients. There was a median follow-up of 84 months. A comprehensive chart review was performed. We found that this cohort had a median residual small bowel length of 76.5 centimeters. An overwhelming majority of our patients required long-term parenteral nutrition. We did find, however, that residual small bowel length was not significantly different between patients who achieved enteral autonomy and those who remained PN dependent at their most recent follow-up. A majority of patients did develop intestinal failure-associated liver disease, and about half of our cohort had one episode of Hirschsprung-associated enterocolitis and at least one central line infection. Many of our patients required intra-abdominal surgery after their index Hirschsprung operation of leveling ostomy. About 30% of these cases were bowel lengthening procedures, and 37% of patients had a pull-through. Of the patients who did have a pull-through, about 38% ultimately required ostomy recreation. In summary, patients with small intestinal Hirschsprung disease require long-term parenteral nutrition, often leading to significant medical comorbidities and complex surgical histories. Small bowel length did not differ between patients who achieved enteral autonomy and those who remained parenterally nutritionally dependent. The next steps in our research will aim to better understand the factors that do dictate the ability to obtain enteral autonomy in this patient population. Thank you very much. Happy to take any questions.
We have time for one question.
Why do you think bowel length did not matter?
Thank you for your question. We were surprised because some other studies in the past have noted that bowel length was a significant factor. I think it's probably due to the underlying dysmotility in the remaining ganglionic portion. We are looking at more granular detail of these patients now, and we're actually comparing them to other patients with short bowel syndrome that have intestinal failure of other etiologies to see what about Hirschsprung disease actually creates this long-term need for the parenteral nutrition.
Thank you.
Thank you.
The next presentation is use of endoscopic retrograde cholangiopancreatography in the diagnosis and management of pediatric pancreatic injury. Presenting will be Scott Eldridge from the Mayo Clinic and Phoenix Children's.
Thank you for the opportunity to present today. Excuse me, I'll go back to that. I chose to do this research to better understand the utility of the use of ERCP in the diagnostic and management of pediatric pancreatic injury. This work is important as ERCP is reportedly underutilized in the initial diagnosis and subsequent managed decision-making in pediatric patients. We have no disclosures. In this project, we tried to determine the discordance between cross-sectional imaging such as CT and MRCP and ERCP for diagnosing main pancreatic duct injury in patients with pancreatic injury. To do this, we conducted a retrospective review between 2009 and April of 2023. We identified a total of 28 patients who had concern for main pancreatic duct injury and who underwent ERCP evaluation. Of these patients, 23 had suspected main pancreatic duct injury on diagnostic imaging, and 5 had clinical concern for main pancreatic duct injury but had normal cross-sectional imaging. Of the patients with concern for main pancreatic duct injury, 7 were found to have a normal main pancreatic duct under ERCP evaluation, leading to a false positive rate of 30% of cross-sectional imaging. Of the patients with clinical concern, 4 of 5 were found to have a main pancreatic duct injury, leading to a discordance of 80% between cross-sectional imaging and ERCP findings. In total, we found a total discordance of 40% between ERCP and main pancreatic duct, ERCP and cross-sectional imaging in diagnosing main pancreatic duct injury. This is an example of discordance. As you can see on the CT scan, there's concern for pancreatic injury with extension of a complete transection and main pancreatic duct injury in this. However, on ERCP, we can see that the duct is intact without any extravasation. In patients like this, ERCP may help guide in the diagnosis, but then also the subsequent management of pancreatic injury, where this patient avoided an operation. Thank you, and I'm happy to answer any questions.
So your ERCP upgraded a significant portion of your patients. I get it. How many of those patients did it upgrade or change your management?
Perfect. Can I go to the next slide on that? I have another slide. Let's see if it works. Well, so for those patients that had an upgraded injury, there was 4. The ones that had a complete partial duct or a complete ductal injury ended up undergoing surgery or an operation. The patients that had a partial disruption, they were actually all managed with the endoscope. So they had a stent or sphincterotomy. So that's how we manage those patients. Thank you.
Our next speaker is Dr. Alexander Hirsch, presenting staged versus non-staged pelvic osteotomies in the modern treatment of cholecystrophy, bridging the gap.
All right. So my name's Alex Hirsch from Johns Hopkins, and I'll be a first-year resident in urology at Jefferson starting in July. So I just want to thank you for giving me the opportunity to discuss the use of staged pelvic osteotomies in cholecystrophy. We have no disclosures. So I'll start with some background on cholecystrophy. In patients with this rare disease, the pelvis is open and rotated outwards, and the pubic rami are separated by a large diastasis. Although single surgery osteotomy was the initial adjunctive treatment, staged osteotomy was introduced later. This technique allows for a gradual reduction of the diastasis over 2 to 3 weeks, with the goal of reducing tension on the final closure. Here we sought to compare the orthopedic complications between the staged and non-staged approaches in cholecystrophy. To do so, we searched our institutional database, and we were able to find 172 patients with cholecystrophy who were closed at our institution. These patients underwent both anterior nominate and anterior vertical iliac osteotomy, which were performed 2 to 3 weeks prior to bladder closure. Using the fixation device, the pelvis was then medially approximated between the time of osteotomy and the bladder closure. Finally, the patient was placed in buccal traction for 4 to 6 weeks. These are several demographic and outcome measures from our study. And as you can see, the important numbers are highlighted in red, particularly the rate of failure of the bladder closure, and then the complication rates broken down by severity and by type of complication. Although we discovered 46 complications overall, only 12 were deemed to be orthopedic complications, and half of these were severe. We did not find a significant relationship between the rate of complications and the use of staged or non-staged osteotomies overall, nor did we find an association between staging and closure success itself. However, on the subgroup analysis of only the primary closures, that is, excluding patients who underwent osteotomy following an initial failed closure, we did find that staged osteotomy was associated with closure success. It's important to note that the study was limited by the fact that all non-staged osteotomies were performed before 1990, after which our institution switched to the staged approach. The sample size of this study was also relatively small, which is an unfortunate reality of research on such a rare disease. Nevertheless, we can conclude that staged osteotomy is a safe alternative to the non-staged approach and can decrease the risk of failed closure. We encourage any exstrophy center that treats cloacal exstrophy to consider the staged approach if this is not already your practice. Thank you for your attention, and I'm happy to take any questions.
I think we'll move on as our time's up for this. So the next presentation is a Frostbite treatment guideline for pediatric patients by Jennifer Hsu. I think this is from Wisconsin.
Good afternoon. The purpose of this study is to describe a single institution multidisciplinary consensus protocol for pediatric frostbite treatment. While it might seem hard to believe in Arizona in the middle of May, it is an important topic, especially because there are no previously published attempts to standardize pediatric frostbite treatment. Inspired by this patient, Children's Wisconsin developed and implemented a guideline based on input from emergency medicine, general surgery, and interventional radiology departments. Grade 1 and Grade 2 frostbite are treated with local wound care. Our study explored the utility of protocol-based thrombolysis for severe frostbite. Patients with Grade 3 and Grade 4 injury, provided that there's no freeze and refreeze injury or contraindications to TPA, are stratified based on age. We used age 12 as a cutoff based on estimated vessel size. The younger patients, who were injured within the last 12 hours, received systemic thrombolysis, while the older patients, provided their injury was within the last 1 to 2 days and they had an abnormal initial diagnostic angiogram, received catheter-directed thrombolysis. These patients are monitored with an interval angiogram, and all thrombolysis patients receive post-thrombolysis anticoagulation. Between 2012 and March of this year, we had 72 frostbite patients seen in our emergency department. 69 required wound care alone. Of those with severe frostbite, 1 patient did not receive thrombolysis and required an amputation. 2 patients received systemic thrombolysis and healed appropriately. These pictures that you'll remember from one of the first slides are from the patient that was seen prior to the guideline implementation. By comparison, this 3-year-old with grade 4 frostbite received thrombolysis and healed as depicted. I'm happy to take any questions, and thank you for your time.
Hey, how are you? I'm Katie Russell from the University of Utah, and I did a ton of work on this in residency. My understanding is that iloprost was just approved by the FDA. Do you guys know anything about that, thinking about implementing that?
So that's correct as far as I understand it as well, that it was recently approved. We have not yet implemented it into our protocol or our patient population, though it is used for a variety of other causes.
So the benefit would be that it's IV and not intra-arterial, right?
Correct. Thank you for your interest and your question.
Thank you.
All right, our next speaker is Dr. John Woodward. He will be presenting national practice patterns of same-day discharge for pediatric laparoscopic cholecystectomy utilizing NISQIP Pediatric Registry.
Good afternoon, everybody. Thank you for the opportunity to present. We have nothing to disclose. So why do we care about same-day discharge? Well, same-day discharge has been shown to have high caregiver satisfaction, decreases economic burden on patients and their families, and reduces overall healthcare costs. When looking specifically at laparoscopic cholecystectomies, national trends have not been well studied, with most research occurring at single institutions. However, in those studies, there have been reports of same-day discharge in elective laparoscopic cholecystectomies as high as 78%. So for our study using the NISQIP-P registry from 2017 to 2021, we identified pediatric patients who discharged on the same calendar day of surgery and compared them to patients who discharged on postoperative day 1 or day 2. We ran multiple different subgroup analyses on multiple different diagnosis codes. We identified the annual rate of same-day discharge and then analyzed the cumulative data. We identified over 15,000 patients who underwent laparoscopic cholecystectomy. And when looking at the annual rate of same-day discharge, we noted a general increase from 2017 to 2021. Looking at the orange line, that is our elective laparoscopic cholecystectomies, that increased from 40% in 2017 to 49% in 2021. And our purple dashed line is the adult NISQIP-P data looking at their same-day discharge rate for laparoscopic cholecystectomies. When we looked at outcomes for not just all elective, or not all laparoscopic cholecystectomies, but all the diagnosis subgroups, we found outcomes were equivalent or improved for the same-day discharge patients. In conclusion, same-day discharge rates for pediatric laparoscopic cholecystectomy are increasing. Compared to adult patients, pediatric patients are 1/3 less likely for same-day discharge, and same-day discharge for laparoscopic cholecystectomy has equivalent or improved outcomes. I'd like to acknowledge the American College of Surgeons, and I'm happy to take any questions.
So why do you think we can't get these patients out as well as our adult colleagues can?
I think a lot of it comes down to, and I know this has been discussed before, but expectation setting. I know in Buffalo, almost all of our elective biliary dyskinesia patients, we are able to get out same day, and that really comes down to expectation setting, everybody in the PACU being on the same page with this patient is supposed to go home, this is the expectation, and then it tends to happen.
Did you look at all at patient satisfaction and number of phone calls or need for prescriptions that night or the next day because they went home?
There has not been much research into that, and NISQIP-P is limited in pulling that data, but we're very interested in exploring same-day discharge topics in general in Buffalo.
Great, thank you.
Thank you so much.
The next presentation is neighborhood-based social determinants of health are associated with decreased helmet use in young children. Caroline Stevens will be presenting from UCSM.
Thank you for the opportunity to present our work. We have no disclosures. Bicycle injuries are a leading cause of injury, disability, and mortality in children, and helmets are known to decrease these risks, specifically decreasing the risk of severe traumatic brain injury, as well as decreasing the risk of facial fractures. However, over 1 in 3 children report that they never use a helmet while riding a bike. We sought to understand the associations between neighborhood-level SDOH, or social determinants of health, and helmet use in our patient population. This work is important because it can potentially guide injury prevention efforts to ensure we're focusing on the communities that are at most risk. We conducted a retrospective cohort study to assess the association between neighborhood-level SDOH and protective helmet use in young children less than 10 between July 2017 and June 2021. Patients were then geocoded and matched to the Social Vulnerability Index and the Area Deprivation Index to assess their level of vulnerability for social determinants of health. We found that for every decile increase in SVI, or Social Vulnerability Index, there was a 23% increase in the odds that the child was not wearing a helmet at the time of the accident. Additionally, for the Area Deprivation Index, there was a 27% higher odds of no helmet use for every increase in the decile for ADI. As you can see on these graphs, which demonstrate the predictive probability with the Social Vulnerability Index and the Area Deprivation Index, this suggests that there is a predictive probability of no helmet use of about 30% for the most advantaged patients. However, for the most disadvantaged patients, the predicted probability of helmet use is about 70 to 80%. These data demonstrate that area-based social determinants of health indices are highly associated with helmet use in young children, and injury prevention programs can potentially utilize these scores, as well as the maps that come with these scores, to identify the communities at most risk and target their efforts better. Thank you.
What do you think the barriers are for these populations for helmet use?
I think when you look in the data, there's a lot of data around kind of perceptions potentially of helmet use, both in regard to having access to a helmet, having a helmet that fits, as well as having your community use the helmets. There's actually a lot of evidence that demonstrates community use impacts your individual use. And I think this gets really at why it's important to consider communities and community factors when you're looking at your injury prevention efforts. In particular, looking at finding community partners, and that's another potential utility of these indices, is they can actually identify schools in areas when you go and utilize the maps. And so you could use that to create partners for this work.
That's great. Thanks.
Thank you.
Dr. Tim Gentilowitz will be presenting utility of renal replacement therapy in infants with congenital diaphragmatic hernia treated with extracorporeal life support.
Thanks. My resident, Daniel, and his wife delivered their first child 2 hours ago, so I'm presenting on his behalf. So we sought to identify any benefit from renal replacement therapy for CDH patients on ECLS. Although it is frequently used at some centers, no guidelines exist on the use of RRT in CDH neonates who develop fluid overload, acute kidney injury, or renal failure while on ECLS. And I hypothesized that RRT is not associated with improved outcomes. So we used the ELSO registry for a 10-year period looking at CDH ECLS patients and then compared RRT use to no RRT use. And then we tried to adjust for severity using propensity score matching for the probability of RRT. And looked at the outcomes of survival and run time. So there were 3,091 patients, of whom 828 had RRT. Interestingly, more patients who had RRT had VV ECMO cannulation, and the ECMO run times were longer for patients with RRT. Interestingly, also the repair rate was similar between those who did and did not receive RRT, but fewer patients were repaired before and after ECLS if they received RRT. And survival to decannulation and survival to discharge were both significantly worse with RRT. So then after propensity score matching for these variables shown here, there really was not much change in outcomes. Now after matching, there's the same number of VA patients, but run times were still longer, and the repair rates were the same between groups, but again, there were fewer patients repaired before and after ECMO, and survival was significantly worse. So in conclusion, RRT for CDH patients on ECLS is associated with worse outcomes even after matching for severity, covariates. RRT patients had longer run times, presumably higher rates of late repair on ECLS, and lower survival to decannulation and to discharge. So perhaps more conservative management of fluid status or renal insufficiency may be favored in this population. That's it. Yes, sir.
Hi, Andrew Zigman, Portland, Oregon. Thanks for the presentation. I'm going to ask you questions about the delving into the data. When you went through it, were you able to parse out the indications for the RRT? In other words, were there some kids who had acute renal injury versus others who just had a temporary abdominal closure, needed fluid off, and therefore got RRT because of that?
Yes, I didn't have space or time to go to those details, but some patients were treated for actual renal failure, elevated creatinine, but the majority were for fluid overload. And so I need to actually dig into that a little bit more detail.
Any gestalt about if it made a difference or not?
It didn't really make a difference.
Yeah. Okay, thank you.
Thanks.
The next presenter is Nikhil Shah from the University of Michigan. Outcomes of a hybrid model for repair of infants with congenital diaphragmatic hernia requiring extracorporeal life support.
Thank you for this opportunity to present our work. As we all know, the timing of CDH repair in the setting of ECLS remains controversial. It's a pretty big why. In parallel with evolving data, we underwent shifts in institutional care models regarding operative timing, from delayed to early repair, and most recently, a hybrid patient-centered model. This study assesses outcomes in infants treated within these three approaches. The hybrid model, a form of personalized care for CDH, accounts for the benefits and shortcomings of both early and delayed repair strategies. We use MRI total fetal lung volume to guide prognostication for need of ECLS and potential timing of repair, namely early repair versus after decannulation. Decision-making is further informed by postnatal clinical status, particularly in the pericannulation period, to determine ultimate repair timing. There you go. The three study cohorts were largely similar in terms of demographics, diagnostic factors, and defect characteristics. Survival to discharge was the highest in infants treated with a hybrid model at 78%, while ECLS duration was the lowest at 10 days. There were no differences in non-repairs or major bleeding complications between groups, as seen in the bottom two rows. Now, this slide is really the crux of our findings. When separating the hybrid model cohort by repair timing, we successfully demonstrate risk stratification based on prenatal MRI total fetal lung volumes. Additionally, day of life at repair and ECLS duration were significantly and expectedly different. Importantly, we see that all bleeding events occurred in infants repaired on ECLS. In the setting of survival rates higher than national averages, these findings further reflect the advantage of this hybrid patient-centered model. Our data demonstrate a physiologic spectrum across infants with CDH who require ECLS and suggest utility of an individualized hybrid model. This approach may be beneficial in discerning patients of moderate severity who could be repaired after decannulation to minimize complications and potentially improve survival. Thank you to the team, and I'm happy to take any questions now. All right.
Thank you.
No problem.
Dr. Alex Hirsch is coming back up to present prenatal diagnosis in the extrophy epispadias complex spectrum of success.
All right. So same as before, no disclosures. So just to give a little background, extrophy, again, is a spectrum disease that includes classic bladder extrophy at the midpoint and cloacal extrophy at the severe end of the spectrum. Unfortunately, prenatal diagnosis rates remain low for these entities, as you can see here. The questions we want to answer with this study are listed here. What are the diagnosis rates? Which imaging findings lead to a diagnosis? And how does this impact closure success and other outcomes? The study design is depicted on the left, as you can see. And then on the right are the results for rates of diagnosis over time for each cohort in its entirety, each cohort including just patients who had prenatal ultrasounds, and finally only patients who were born in the US. And now some numbers. So gestational age was similar between cloacal and classic bladder extrophy, around 20 to 22 weeks of gestation. Prenatal diagnosis was associated with higher rates of closure at centers of excellence, although this did not necessarily translate to more successful closures. And then finally, fetal MRI was used significantly more often to diagnose cloacal than bladder extrophy. Oh, all right. Finally, the frequency of each ultrasound finding is shown on the left, with the highest frequency findings highlighted. Sensitivities of the selected findings are shown on the right, and you should note that absent bladder, although it was the most common for classic bladder extrophy, was not the most sensitive. So what's the significance of all this? First of all, the diagnosis rate increased across the study period, but still remains low, especially for classic bladder extrophy. Fetal MRI is not utilized highly, but could potentially be an important diagnostic tool. Successful diagnosis is important because it may increase the likelihood of closure at a center of excellence or any high volume center. It may improve family and patient well-being, and it may increase rates of successful closure, although we did not find this in our study. thanks for listening, and I'm happy to take any questions.
So other than use of fetal MRI, are there any other ways that we could improve prenatal diagnosis?
It's a good question. I mean, you know, it varies, I think, a little bit between the two conditions. Cholecystrophy is definitely a larger defect and, as you saw, is diagnosed at a higher rate. But at the same time, at our institution, we do, our protocol is to do an MRI for any patient that's suggested of having cholecystrophy. So, yeah, I mean, I don't know, I kind of feel like if MRI is not good enough, it's hard to think of other imaging modalities. Maybe there'll be something that comes down the pike in the future. But
Great, thank you.
yeah. Thanks.
The next presenter is Koichi Tsuboi, presenting maternal consumption of high-fat diet impairs susceptibility to neonatal sepsis and impairs goblet cell differentiation in utero in mice.
Thank you for the opportunity to present today. I also have no disclosures. The purpose of this research is to investigate the impact of maternal high-fat diet on fetal intestinal development and alteration in immunity. The results from this study suggest that maternal high-fat diet can impair offspring susceptibility to pathogens, increase intestinal inflammation, and alter cell differentiation in response to inflammation. The C57BL6 females received high-fat diet for 8 months prior to the mating and throughout the pregnancy. These females significantly gained weight after 8 weeks of treatment, as well as the serum insulin level. The newborn offsprings received 2.5 milligram per kilo LPS on day 1 and to induce entoxemia, and samples were collected 6 hours later. The high-fat diet offspring present hypoglycemia at birth and showed elevated pro-inflammatory cytokines after 6 hours of LPS injection. In addition, ultra blue staining revealed ultra blue staining of the ileum revealed the increase of goblet cells at the baseline, and the numbers decreased after 6 hours of LPS, whereas the numbers increased in the normal diet intestine. So in conclusions, maternal high-fat diet increased susceptibility to abdominal sepsis in the offspring and altered intestinal cellular differentiation towards goblet cells. These findings may offer insights into potential underlying mechanisms of intestinal disorders in infants from high-fat diet mothers. Thank you. I'm happy to take any questions.
All right, we'll move on. Thank you very much.
Thank you.
Our next presenter is Rahul Gadi, presenting intestinal fatty acid binding protein and lipopolysaccharide binding protein as dual biomarkers to define disease severity in NEC.
Good evening, everyone. Thank you for the opportunity to present our group's work looking at intestinal fatty acid binding protein and lipopolysaccharide binding protein as dual markers to define disease severity in necrotizing enterocolitis. We hypothesized that serum IFABP and LBP, either individually or in combination, can correlate in discriminating disease severity and improve diagnostic efficiency in our preterm neck piglet model. We used our established piglet model, neck piglet model of spontaneous neck, where these samples were collected at delivery and again at necropsy. These samples were then analyzed using ELISA to determine the serum concentrations of IFABP and LBP. The samples were analyzed between the initial and the final samples, the relative fold change, which in the serum LBP showed no significant difference. For no neck in green, mild in blue, and moderate to severe in red. However, in contrast, the serum IFABP levels were significantly different for the three groups, and showing the best significance to discriminate disease severity between no neck versus moderate to severe neck, approaching significance between mild versus moderate to severe, and no significance observed between no neck versus mild. We then used the combination of both markers to correlate for disease severity, which did not show any meaningful correlation between the three disease severity types. We then performed a ROC to establish the serum IFABP levels for diagnostic accuracy and cutoff value appropriation. Serum IFABP levels greater than 39 picograms per ml distinguished between mild versus moderate to severe neck with a 88% sensitivity and 67% specificity. We concluded that serum IFABP can distinguish between the incidence and severity of neck, but the diagnostic efficacy is not enhanced by serum LPP assay for neck diagnosis in the piglet model. Thank you.
Do you think these biomarkers get elevated at the time of where you have clinical manifestation of the disease, or could you see it could you use it clinically as a predictor of the severity?
At this time, we are not able to predict the onset of neck, more so to determine the severity once neck has been established. We are looking into future directions where we would be able to discriminate between the two before the onset.
Great, thank you. Next presentation is the impact of infectious source on pediatric ECMO outcomes and sepsis, presented by Tiffany Zenz from Phoenix Children's.
Good afternoon. I have nothing to disclose. Pediatric sepsis can result from a variety of infectious etiologies, including bacterial and viral pneumonias, as well as bloodstream infections. The primary objective of our study was to determine whether the infectious etiology of the sepsis was associated with mortality. Our secondary objectives were to determine if polymicrobial infections or a specific infectious organism affects mortality in children on ECMO with sepsis. In order to perform this study, we did a retrospective review of 155 pediatric patients on ECMO with sepsis. Culture data and infectious disease notes were reviewed in order to determine the etiology of the sepsis. We then used a univariate and multivariate analysis in order to determine if there was a relationship between the infectious etiology of sepsis and mortality. We divided our patients into 5 groups based on the etiology of their sepsis. The mortality data is displayed above. We found that children who had both positive respiratory cultures and positive blood cultures had the highest rates of mortality, with a hazard ratio of 7.6 on ECMO and 4.5 at discharge, when compared to those children that just had bacterial pneumonias. We then classified our children into those that had polymicrobial infections and monomicrobial infections, and found those children with polymicrobial respiratory viral infections had higher rates of mortality with hazard ratios of 3.2. We did not find a mortality difference in those children who had polymicrobial bacterial pneumonias or polymicrobial bacteremias. Finally, we analyzed the specific organism that was grown on our culture data. We found that those children who had viral, RSV, and COVID pneumonias had higher rates of mortality. We did not see a difference between mortality based on organism in either bacterial pneumonias or bacteremias. In conclusion, our study of 155 patients on ECMO found that those children who had both a positive respiratory and positive blood culture at time of ECMO cannulation, those with polymicrobial viral infections of the lungs, and those who had COVID and RSV infections had higher rates of mortality. With that, I'm open for any questions.
You mentioned that you had the positive results at the time of cannulation. Did you already have those available to counsel the parents, or is that just in hindsight that's what was positive at the time of cannulation?
So looking over the infectious notes and the culture data, almost all of the children had results at the time of cannulation. So the idea behind the study was if we can predict kind of how the patients would do, we could do better counseling at time of cannulation. We had looked at using the ELSO data for this group, but unfortunately the culture data in that national database is for their entire hospitalization. So you can't tell if the cultures were like a month ago and they've been hospitalized for 3 months, if it actually happened on ECMO and it was like a nosocomial infection. So we couldn't determine it was truly the etiology of their sepsis. Thank you.
Dr. Catherine Snyder will be presenting hyperinflammatory state seen in active necrotizing enterocolitis remains even post-recovery.
Thank you for the opportunity to present our work. We have nothing to disclose. Necrotizing enterocolitis is a devastating gastrointestinal disease of prematurity that has been shown to be associated with a hyperinflammatory response. We chose to do this research to further explore that hyperinflammatory response, specifically after recovery from NEC, and we hypothesize that these patients will continue to have a heightened inflammatory response even after recovery, which could be significant as these patients age. To study this, we collect tissue from infants with NEC, recovered from NEC, and those without NEC. We create enteroids, which are mini 3D structures that mimic in vivo conditions. We subject 1/2 of those enteroids to in vitro NEC, inducing treatment with LPS and hypoxia, and use the other half of the enteroids for controls without treatment. On initial tissue PCR analysis, there was no difference in inflammatory markers between a patient that has recovered from NEC compared to those without NEC, and there was a significant difference shown between active NEC tissue and both recovered and non-NEC tissue. Moving on to enteroids made from that tissue, we now see that following the second hit of in vitro NEC induction, the recovered NEC enteroids now demonstrate a significant increase in inflammatory markers compared to enteroids made from tissue without NEC. And now there is also no difference between active inflammatory markers there compared to those from recovered NEC enteroids. This is in contrast to the initial tissue analysis prior to the second hit. RNA sequencing performed also shows a significant upregulation of hyperinflammatory markers in the treated enteroid groups compared to control following that second hit. So our research shows that enteroids from patients that have fully recovered from NEC do retain that tendency towards a hyperinflammatory state post-recovery, no different than what is seen in active NEC when subjected to a second hit. This may impact an illness trajectory for these patients after recovery from NEC, and we plan to treat these enteroids with potentially clinical applicable anti-inflammatory agents going forward. Thank you, and I'll take any questions.
Agostino Piero, Toronto. Thank you very much. Very interesting. We look at enteroids from NEC patients, and we found a difference also depending where the enteroids are derived. If they're derived from an area very inflamed and very close to necrosis, or farther away from that. Have you noticed any difference in that?
We have also noticed a difference in that. The inflammatory markers are a lot higher where it's more necrosed. We do tend to try to take an area that's near the necrosed spot, but not necessarily right at the worst spot, depending on how much tissue we're given.
And away from that area, have you find the same difference that you showed now?
Yes.
Okay, thanks.
Great, thank you.
Thank you.
The next presentation is clinical predictors of spontaneous intestinal perforation versus necrotizing enterocolitis in very low birth weight neonates by Ghetto Dantes. Oh, I said that right.
Thank you for the opportunity to present, and thank you each and every single one of you for your conference resilience. I have no pertinent disclosures. I'm standing on the shoulders of giants when I say, many of whom are in this room, when I say that NEC and SIP are two of the most devastating diagnoses of premature neonates. As two distinct clinical entities, we are now starting to understand that NEC may benefit from upfront laparotomy, while SIP benefits from upfront peritoneal drainage. However, the challenge is, and in some cases, that it's difficult preoperatively to accurately distinguish the two as the clinical presentation often overlaps. Therefore, we reviewed clinical characteristics of neonates with SIP and NEC and produced a novel prediction score to specifically to improve our preoperative distinction of these two diagnoses. We did so by performing a retrospective review of neonates treated for NEC and SIP at our institution. All preoperative clinical variables were reviewed, and significant findings were analyzed using multivariable stepwise logistic regression. We ended up with 338 neonates who were treated for NEC and SIP. 269 had the definitive diagnosis of SIP, while 69 had the definitive diagnosis of NEC. I'm going to quickly go through some of the pertinent findings that were significant. In SIP, lower gestational age, lower age at surgery, lower CRP, and higher WBCs, white blood cell counts, emerged, among other elements, as being highly associated with SIP, while pneumatosis, abdominal wall erythema, being on goal or advancing feeds, or history of a PDA treatment were associated with NEC. Following multivariable logistic regression, 4 elements emerged as highly associated with NEC: older age at first intervention, feeding history, pneumatosis on radiographic imaging, and abdominal wall erythema. We then utilized these clinical variables and put them into a scoring algorithm that was up to 8 points for being the most highly associated variables with necrotizing enterocolitis. Then, setting a threshold of 1.5 as predictive of NEC, we plotted this ROC curve that produced an area under curve of 0.82, which was highly predictive with a specificity of 95%. So to summarize, we utilized highly associated clinical variables to develop a scoring algorithm that highly predicts NEC versus SIP in very low birth weight neonates. This score can be particularly useful in the absence of pathognomonic findings such as pneumatosis. We believe this score can be used at bedside to improve preoperative diagnostic reliability and future research studies to improve preoperative and intraoperative diagnostic concordance. Thank you, and I look forward to your questions.
Did your analysis look at platelet count?
I'm sorry, I missed that.
Did your analysis look at the platelet count and the rates of thrombocytopenia?
Yeah, interesting enough, platelet counts was not, may have been because we had both very low birth weight and extremely low birth weight neonates with the median birth weight of about 500 grams for both our diagnoses. So, and both were fairly sick, so that may have been why that factor was not significant. Thank you very much.
Our last presenter of this session is Dr. Ahmed Samra, presenting Investigating the Optimal Timing for Resection of Congenital Pulmonary Airway Malformations, a NISQIP Study.
Okay, thank you everyone. Thank you for being here today. Thank you for sticking around until the last presentation. I use the mouth. Okay. There is nothing to disclose. Congenital pulmonary airway malformations are rare congenital anomalies that are advised to be resected to reduce the risk of infection and malignant transformation. Our research aims to explore the relation between age, weight at the time of resection, and surgical outcome. We utilized the American College of Surgeons NISQIP pediatric database between 2017 and 2021, focusing on patients aged 7 to 17 years at the time of resection. We divided the data into 2 age groups using 8-month cutoff into 2 weight groups using 8 kilogram cutoff to compare 2 groups with each category. The variables of interest included operative time, blood transfusion, length of stay, readmission, and other factors. Bivariate regression analysis performed. 1,744 patients met the study criteria with about 50% of resection performed before the age of 8 months and before reaching 8 kilograms. Minimally invasive surgery was utilized in 58 of the resections. The older age group had lower odds, like in the age chart. The older age group had lower odds of blood transfusion and unplanned intubation. However, the older age group had slightly longer operative time and higher rate of readmissions. The higher weight group showed shorter hospital stays after resection, lower odds of postoperative pneumonia, lower rate of readmission, and also a longer operative time. Both older and higher weight groups showed non-significant trends towards lower rate of composite surgical site infection, need of oxygen at discharge, and ventilator dependence, along with a higher rate of preoperative blood transfusion. Our results suggest that delaying CPAM resection until the age of 8 months or a weight of 8 kilograms leads to reduced surgical complication and improved outcome. However, it also leads to slightly longer operative time. Our limitation, there was no practical method to extract the pathological findings of the resected parts so we can assess the evidence of infection or the potential malignancy. The future direction to have multicentric studies recommended to examine the effect of surgery timing on long-term outcome. Further research should also explore the molecular and pathological changes related to age, weight, and influence surgical outcome. Thank you. Happy to take your questions.
Why did you pick 8 months and 8 kilos?
Okay, that's a good question. Thank you. So part of the thing it's what we use in UNC, like that 8 month cutoff, sometimes like 6 kilograms, 8 kilograms. So we just want to explore this trend. Is it like valid? Is it like when we explore in NISQWeb, does it sound or not?
And did you do any kind of sub-analysis for just thoracoscopic, since that's a very different surgery and postoperative experience?
What's that?
Did you just look at thoracoscopic instead of, it looks like you combined open and...
Open and laparoscopic, yeah. Like there is like a trend to increase using laparoscopic compared to other versions of NISQWeb that we also explored, but we included all like laparoscopic, open, and convergent as well.
Benham, University of Buffalo. It looked like you went all the way down to 0 months of age. I'm curious in the 0 to 1 month cohort if those included patients who perhaps were sicker to begin with, and that may have contributed to the higher complication rate rather than those that were operated at 3-4 months.
I didn't get. You mean like the first year or neonate age maybe have like higher rate of complication, and we include all, or?
Why did you operate on those rates?
Yeah, I get, like, we just use the data as is, like we extract the data from NISQWeb as like this age group. It's not most of the cases like performed around the 0 to 1 month. It's like, looks like if we take the 8 month cutoff, it sometimes looks like a bill shaped. Most of the patients are like resected like lower than and more than 8 months, but not at the first months of age and like older than 10 years or something.
All right, thank you very much.
Thank you.
I'd like to thank all the presenters and thanks for coming to the session, and I think we're all done.